Self-Management Week. Tackling mental health stigma and discrimination in healthcare. Dr Patty Lozano-Casal, Programme Manager, SAMH. Follow us on X at Self-Management Scot and Alliance Scot. Health and Social Care Alliance Scotland.
Good morning, my name is Patty Lozano-Casal and I work at SAMH. I'll give you a bit of an overview in a second, but I just wanted to say thank you again to the Alliance for giving Moray Wellbeing Hub and SAMH space today as part of the Self-Management Week to just share a little bit about the work we are doing and also how we can support anyone who wants to take action to challenge mental health stigma and discrimination. But more importantly, to share with you the guidance that Moray Wellbeing Hub has actually produced with support from SAMH. As a national programme, we feel it's very important to shine a light where local areas are taking action and how they are tailoring some of the national resources to meet the local needs. So I'm going to share my screen and also to share, I'm here today with my fantastic colleague, Rachel Gray. She's project officer for setting, so leads on the work that we do around health and social care, and she will be helping facilitate today. I'm going to share some data, some evidence that we collected, trigger warning if some of the data can be quite hard-hitting. So if you find yourself affected by it, please take care of yourself. Feel free to take a step back, come back, or leave altogether. And if you need support, please message one of the organisers. You should be able to do that through your chat. But hopefully nothing like that will happen. I just thought of mentioning that to start with. So as I said, SAMH is the National Programme to End Mental Health Stigma and Discrimination, and our vision is for a fairer and more inclusive Scotland free from mental health stigma and discrimination. We are funded by the Scottish Government and managed by SAMH, also known as Scottish Action for Mental Health, and the Mental Health Foundation. And we are, our mission is actually guided and supported by people with experience of mental health problems. We challenge mental health stigma and discrimination, and particularly in the areas where we know people experience the highest levels of stigma and discrimination, which include communities and priority groups, health and social care, workplaces, and education, young people spaces. We also do a lot of work around communications, national communications, and campaigns to challenge stereotyping and also social attitudes around mental health and mental illness. We influence change in behaviours, cultures, and systems so that people with experience of mental health problems are respected, valued, and empowered to achieve the outcomes important to them. So I thought not to patronize anyone, but people have different ideas and experiences around stigma and discrimination. So I thought to start with, so we are all using the same terminology or understanding the same when we mention stigma and discrimination. Thought of sharing our own definitions from the programme. So at SAMH, we define stigma as the negative attitudes and beliefs based on a preconception, misunderstanding, or fear of mental health. And because it's quite abstract, we also help people understand stigma by breaking it down into different types. This is all evidence-based so that you're aware. So it's not SAMH coming up with this. This is what we use based on the research. So public stigma is the social attitudes and perceptions, basically how mental health is portrayed, mental health illness and mental health in general is portrayed in the media, things like how mental illness is, I guess, portrayed in music, videos, film, articles in newspapers. When something happens, people tend to go really quickly as people have mental health problems. So that's what we try to do to challenge those types of stigma. We also talk about self-stigma to help people tap into the internalized stigma, so how the feelings of shame that they might have, feelings of being a burden to others, and clarify that those feelings are valid, but they are not they shouldn't happen. And we want to make sure that people feel that they can actually own their mental health problems and their recovery. So hopefully that makes sense. Stigma by association, stigma that people looking after, working with people with mental health problems or mental illness experience because of that association, whether they are friends, family, professionals, advocates, etc. An example of that might be, for example, people working in the mental health nursing profession, where they might be told that's not real nursing because, you know, you're working with people X, Y, and Z. Or, for example, a parent going with a child to a hospital, an A&E, with potentially injuries from self-harming. They might be told, you're not looking after your child, you don't care about your child. That kind of stigmatizing attitude, not wanting to understand what's going on in their family, and the blame culture. And then there's a structural stigma that comes from how institutions are set up, the policies, the procedures, the practices, and that already leads to people being stigmatized without even putting a foot on those premises. Discrimination is when a person performs an action, whether intentional or unintentional, that creates barriers and inequality for people with lived experience of mental health problems. So stigma, we think about it as the thoughts and the attitudes. Discrimination is the actual actions. And just to flag, all experiences of stigma discrimination are intersectional, meaning we are not only people with mental health problems, we are also people that have a gender, have economic status, have you know, all the different protected characteristics. You might have other disabilities and so on. So it's very important that when we talk about tackling stigma, we think about all the different social identities of people. And this is particularly important for those working within healthcare settings. So why is tackling stigma foundational to improving the outcomes for people? It presents barriers to well-being and recovery. It acts as barriers to prevention and early intervention. It has a direct impact on care and treatment a person receives, and actually even access to that care and treatment. It leads to significant inequalities in health and affects life outcomes overall. We know from the evidence base that people with mental illness live up to 20 years less than people who don't have mental illness, and that should stop. And it results from human rights not being upheld, the right to health, for example. So, and right at the peak of the pandemic, of the COVID-19 pandemic, we did a national poll of 1,000 people. And we did find that 80% of people said that attitudes towards mental health have improved in the last 20 years, particularly during the pandemic. I think there was more conversation on mental health, how people were struggling. So there was perhaps a false sense that stigma was actually disappearing, that the job was done. But we also found that 71% of people had experienced mental health stigma, most commonly from someone they knew. And the 31% of people, that's a third, would stop themselves from speaking about their mental health for fear of getting a negative reaction. So those findings were quite interesting in themselves. So then we went to actually look at, are we talking about stigma relating to mental health, or are we talking about stigma relating to mental illness? So we carried out a study, a national study, the first of its kind in Scotland, called the Scottish Mental Illness Stigma Study. And this was following a methodology used in Australia and also in Canada. We wanted to get also an international perspective on this, but for us it was more important to get a sense of what the experiences of people with mental illness were in relation to stigma and discrimination. So this study explored how people with experience of severe, enduring, and complex mental illness face stigma and discrimination in 14 different life areas, including relationships, that might be within family and friends, healthcare and mental health services, employment, and also social media. And when we talk about mental illness, we didn't ask people to have a diagnosis. So people could, as long as they felt they had experienced one or more mental illnesses in the past 12 months prior to this research, it was okay for them to participate. And you can see here that most of the participants self-disclosed personal disorders, severe treatment-resistant depressive disorders, and other types of mental illnesses. And what we found is that years of stigma and discrimination have left people with mental illness feeling ashamed and assuming that the public, people in positions of power, think the worst of them, that even that they are dangerous and to blame for their conditions. And that the impact of discrimination is that for more than half of people who responded respect themselves less because they think they will never recover, they will never get better. And these were very hard-hitting learning points for us in the program, having worked over 20 years to address stigma and discrimination. They gave us more power, more energy to actually continue with that movement for change. So what we asked people then was to tell us about the types of stigma and discrimination they experience in the 3 areas of the highest impact. So out of those 14, we asked them to select only 3, the top areas for them. And what we found was that there was a thread that went from experiencing stigma around their mental illness to anticipating experiences of stigma, to then withdrawing from settings or those life domains they chose out of fear of experiencing stigma. And what we have here is just a summary of the top life domains or life areas they selected. So you see that in terms of frequency, how often people experience stigma and discrimination, they chose as the top life domain their own relationships, social media, and then you can see healthcare and mental health care were selected by many people. If you go to the impact, so perhaps less frequent but more impactful was, and again in relationships, followed by employment, and then mental health care and healthcare. So you can see the healthcare and mental health care are high up in those. So then what we have here is looking really at the results that we found, the findings around healthcare settings. So all of this is in a report. I can share the link, so please don't worry, and I'll share the slides as well. But you can see here, I was talking about that thread, and you can see how 85% of people experience unfair treatment when trying to get help for physical health problems in healthcare. That led to 32% of them anticipating being pressured into receiving physical healthcare treatment they did not think was necessary, or 81% expecting to be treated unfairly when trying to get help for their mental health problems. And that led to people withdrawing from those services. 85%, again, have stopped themselves from asking for help for physical health problems. Half of those people who selected this life domain actually have avoided calling an ambulance or attending A&E in relation to their physical health. And almost 50% of them, almost half of the people, have stopped themselves attending general health checkups. But we also found that there were some positive feelings amongst people, and they shared, been listened to, validated, collaborated with, and treated with kindness, compassion, understanding, were all highlighted in positive experiences. So although it's not all bad, there needs to be more work done. Mental health services, same pattern, experiences, anticipation, withdrawal. And you can see there, 81% of people reported having been unfairly denied help for their mental illnesses. And that led to 81% expecting to be treated unfairly when trying to get help, and 80% stopping themselves from getting help for their mental illness. What this means is that people are really struggling, and stigma is actually underneath all of this. We also looked at the themes coming from open comments, and we identified that there were key themes that people were talking about when it came to mental health care. Barriers to access was obviously one of them: denial of services, unavailability of appropriate assessment or treatment, inflexibility in waiting times, but also problems with the medical model, the power imbalance that exists between the professionals and people with lived experience as experts of their own experience and their own bodies, and issues with diagnosis as well. Ineffective and compassionate and fair treatment, typical assumptions and prejudice, lack of knowledge and inappropriate treatment was also highlighted, and also erosion of trust. So that kind of leads to that withdrawal, people avoiding services and not wanting to disclose, and being very wary of what they disclosed and how. So we also asked them what needs to change, and Jane was talking about systematic changes. That's basically what they ask for. They ask for societal values and understanding. So at personal level, they want people to have more awareness and understanding, better education. They want to be included and accepted across society, and they just are asking for kindness, empathy, and compassion, which costs nothing to healthcare and mental health services staff. Socioeconomic exclusion, reducing social inequality and addressing that exclusion, changes in policy and systems, and also reasonable adjustments and considerations, which are typically spoken about in employment settings, but not in healthcare settings, which is quite interesting. And then obviously changes to services and support, removing barriers for people to access services, timely mental health support, getting the support they need at the time they need it, where they need it, and more variety in therapy approaches, so it's not just following a medical model, and also staff training and services. They also talked about the negative representations of people living with mental illness and the need for thinking, like being more mindful of language and having greater visibility of people with mental illness. And I think that is key. We are talking today about guidance for people with lived experience to challenge the settings themselves. But I think it's important to also recognize that these professionals work within a system that is far from perfect. They have significant financial and resourcing pressures that limit or can limit the quality of care they provide. They have important issues with workforce recruitment and retention that leads to long waiting lists. There's impact on staff well-being with the lack of capacity and resource. They have potentially no time off, breaks, which then leads to them having their own mental health problems and illnesses. After all, we all have mental health. And that can lead to them feeling they can't disclose in their own healthcare and mental health services where they work. And that can put barriers to opening conversations with others like service users. That's not to say that that's okay, but it's helping understand perhaps where there might be at when we're trying to open a conversation they are not interested. But unless stigma is addressed, inequalities will persist and affect health and life outcomes overall. So going back to what works then, and we're talking about lived experience, there has been a review, an international review called by the Lancet Commission about mental health, stigma and discrimination and what works. And they again reinforce the need for, I guess, a blended approach where people with lived experience and their voices need to be at the core of any intervention. Education and capacity building to ensure that people understand mental health problems and they can empathize and sympathize with people's experiences and pay attention to what they go through and identify ways of minimizing damage and risk and supporting recovery. And also building the capacity of people with experience and professionals to champion, to influence stigma-free environments. And that's where people with lived experience come in, and this guidance comes in, because I think that it really provides a good understanding of healthcare and mental health care services. So people with lived experience can actually navigate their way around it, and also get tips and resources and ideas as to what they might be able to do for themselves and as a collective. So thank you for your time, and I hope you join the social movement for change. But I'm guessing that if you're here, you're already there. So thank you for all your support and for listening to me today.